Welcome to the Limitless Leaders podcast series brought to you by ASPS, the Aesthetic Society, and the American Hernia Society with the generous support of Allergan Aesthetics. My name is Dr. Ashley Amalfi, and I'm a board-certified plastic surgeon at the Quatella Center for Plastic Surgery in Rochester, New York, and I am the chair of the ASPS Women Plastic Surgeons Forum and the Limitless Leaders Steering Committee member. Please join us for Season 2 of the Limitless Leaders podcast, where we dive into the stories of extraordinary women making a significant impact in our field, as well as the men who are supporting them to get there. We are breaking gender barriers and inspiring the next generation of leaders.
You're listening to the Limitless Leaders podcast series brought to you by ASPS, the Aesthetic Society, and American Hernia Society, with the generous support of Allergan Aesthetics. I'm Dr. Donna Tepper, today's guest host of Limitless Leaders podcast. I'm a plastic and reconstructive surgeon at Henry Ford Hospital in Detroit, Michigan. I've been practicing for approximately 20 years, focusing on body contouring and aesthetics. I've been the division head for the past year and a half. On today's episode, we have two very special guests, Dr. Wendy Chen and Dr. Liza Wu, to discuss sexual harassment and misconduct. Welcome, ladies. I'd like to start by thanking you for your time to participate in this podcast, and let's begin by introducing yourself and take a little time to talk about your practice and where you work.
I'm Wendy Chen. I am an assistant professor at UT Houston. I'm in my second year of practice, and I'm primarily a hand surgeon, and I also do pediatric plastic surgery. Thanks for inviting me today.
Yeah, thank you very much. My name is Liza Wu. I recently, after 16 years at University of Pennsylvania, where I was a professor of plastic surgery there, moved to Florida, and now I'm currently in private practice. My areas of expertise have been breast surgery, both in the extirpative as well as reconstructive arenas. I want to thank Dr. Tepper and Dr. Chen and Limitless podcast for this invitation.
Thank you both. So this is an exciting time because you guys are both at two extremes or different parts of your practice, which I think to make this an even better experience from different viewpoints. So Wendy, earlier in your practice, and Lisa, you've had some time just like I have. So I think that this gives us a lot more color to what we're going to talk about here. Obviously, this is a hot topic with the Me Too movement and lots of information in the media. So I thought we should probably first talk about what is sexual harassment misconduct.
Sexual harassment is essentially, from what I interpret it as, is unwelcome sexual advances or behaviors that either verbal or physical that make someone feel uncomfortable. Typically, it comes from someone who is either at the same level or even at a higher station than you are, and that you feel somewhat threatened with regards to either professionally, there would be repercussions as well as personally, obviously.
Yeah, I'd say legally, the only thing I have to add that sometimes I think people don't necessarily realize in our field is that anything that interferes with effectiveness of your work, that includes visual references of a sexual nature, and it can also come from subordinates. And in our world, that includes patients as well as non-physicians.
Oh, that's a really good point, Wendy, when you brought up the variety of people that this could come from and narrowing it down to affecting your work. Because I too kind of thought, at first I thought between a man and a woman, but it could be a woman and a woman or anyone.
Yes, absolutely.
And just as an aside, I thought when we say the word sexual harassment or misconduct, is there an image that comes up, Lisa, in your mind when you think about this or an event?
Well, I think that's what's ultimately very interesting, right? Like, it's one of those things when you know it when you see it, but there's a lot of instances in which it's happening, and others may not recognize it, and you yourself may not recognize that it's actually behavior that can constitute as either sexual harassment or sexual misconduct, right? And it's kind of like when it's an egg, you know it's an egg. When it's color blue, you know it's color blue. But then there's circumstances in which it's not as clear. And I think that's where things can get a little bit cloudy.
I think what's important to recognize is, as Dr. Wu said, you're in charge of diagnosing it when it occurs in your ecosystem. And so a lot of times, especially let's say us coming up in the surgical training system that we have, maybe sometimes you're like, well, maybe that's not, like you're kind of almost like kind of gaslighting yourself. Like, like, I don't want to cause a problem. Like maybe that's not, And then the other thing I think that is important for us to be clear about being better at diagnosing it when it occurs is that we have to also protect our staff and our patients, because sometimes maybe we as the physicians are not the quote victims, but it could be also people that we kind of have a responsibility to.
Right. I mean, if we enable the behavior. But do you think we should go back and just kind of look at what do you think would be absolutes when we look at this? Just Lisa, like what you said, at one moment you may not, you think it, exactly what it is, but there may be other instances where it's a little bit less difficult to say, oh yeah, this is what happened.
I mean, absolutely. And I can probably tell you that each one of us has a story, right? In which sometime during our education or our training, something happened and it made you take pause. But in the same breath, no one else seemed to have thought it was unusual, and you question it, right? So, for instance, when I was a medical student, I had an attending ask me to dinner. And I assumed it was a dinner with all the other medical students on the surgery rotation. And when I showed up, I was the only one there. And it was a dinner, and it was in a public place, and it was very nice, and it was appropriate. We talked about work. He asked me about myself. There was no unwanted touching or sexual comments or anything. But I left thinking to myself, well, wasn't that odd? Why was I the only one invited? Why did nobody else get invited? And does that constitute sexual harassment or sexual misconduct? And I think the lines can be blurry for sure. But yes, if say somebody traps you in the elevator, pushes you against the wall, and touches you without wanting it, that is clearly, right, sexual harassment, sexual misconduct. And again, I think it's when it's unclear that that I think it's harder for people to report or to understand that that's also can be constituted as sexual harassment or misconduct.
Absolutely. What a difficult experience to go through. That is right up there with doesn't feel right. Why didn't it happen to anybody else? Thank you for sharing that, because it's excellent. It's an excellent example of where does this fall. It's not right. And when you can listen to your intuition, I think that's paramount.
Right. And then the question then becomes, what happens then? Do you report it? So my attending took me out to dinner and asked me about my future and what I wanted to do in surgery. Like, does that constitute a sexual harassment or sexual misconduct, And I could see why people would hesitate to bring that up, because to the outside world, it may not seem like sexual misconduct or sexual harassment.
Right. Exactly. What do you think, Wendy?
I think that's a really perfect example of this gray zone that we're trying to define. And I think there's a lot of people with stories like this. And I think the input that I have on this would be that this is exactly why we should talk about it. So I think just like, if we put up like indications conference or M&M, where we talk about, situations that aren't easy, right? Like it's easy to diagnose X, but when it gets a little bit more subtle, how should we regard it? And that's how I think, as a community and of surgeons, that's how we're going to hone in on what we define clearly as sexual harassment or misconduct.
So you had said a little bit about that this has probably happened to a variety of people. Do you think it's more the expectation, or do you think it's an exception?
Yeah, unfortunately, I think there's a bit of well, when I trained, I think there was a bit of expectation when I went through surgery training, in which I was one of seven, all men except for me, sort of training in surgery, and it wasn't quite like that. But I'm hoping that things have changed more recently, and I would love to hear that it has changed.
So, I mean, I think every institution and culture and regional can be different in terms of how things are now and progress. And I think the situation Dr. Wu described could potentially be, let's say, one crumb on a path of grooming. Also, that's something we have to be really aware of. So, yeah, I think there are stories that I've heard that still sound very much like stories from 20 years ago. And then there's stories that I've heard from 20 years ago that sound much more like stories that we would hear nowadays, like women who are like, oh, my superior and my colleagues were very supportive, and I never got a hint of any sort of thing. And so I think it's about the individuals in our communities and our ecosystems more than necessarily it's always about the time. I think the times are important as a global sort of step forward in progress, but sometimes I think it's your local institution and culture.
Right. I always wonder. So, Lisa, I have a similar experience where when I was in general surgery, there were 3 women in our program, and our program director brought in 5 more women from another program in order to even out the department, which is unique in itself.
Yes.
And we were referred to as the Dixie Chicks or the Louisiana Purchase because we all came from New Orleans. And I kind of thought it was funny, but it was a situation where one man, our program director, appreciated the difference in setting and purposely brought more women into the program. But Wendy, to what you were saying, you wonder if as we become more aware of the situation and more women are in medical school. I mean, half of the medical schools have women in them. It just makes me wonder: is there more awareness to it, or do you think there's just as many occurrences?
Well, 20 years ago, Susan McKinnon did a study in cardiothoracic surgery about how many instances of sexual harassment were occurring or being reported. And a few years ago, I had repeated the studies specifically for plastic surgery, and the numbers that were being reported were not different. And then recently, in the last 18 months, I kind of redid that data specific to plastic surgery, and actually the instances that respondents reported increased. And we haven't completed the study or written it up yet, but I sort of attributed that to more people are willing to talk about it now, because the incidents that we were looking at, both a few years ago and 20 years ago, like, we assume that that's underreported, just like in lay people numbers, that they are underreported. And so I think that there had to be a gap that needed to be closed between people who are willing to report and what is actually happening. Now, what actual events are occurring? Let's say there was more rape previously, and now it's more quid pro quo, or like like coercion or something. Or maybe now people are better at diagnosing. Oh, if somebody shows me a picture like this or makes an off-color joke, like that is it. That meets the threshold of calling it sexual harassment. Um, so there could be that. Difference in severity or types of events occurring also. But that's kind of like a big picture of if you want to talk about numbers,
That's really, thank you. I mean, that's excellent work and obviously very pertinent to this. So thank you. In your research, and I'm sorry I didn't go over that before this, but did you look at? Did you quantify the instances as we had kind of talked about with absolutes versus gray area? Was there some distinction between that?
Yeah, so we distinguished between harassment versus assault or coercion, like sort of the more severe instances. And I would say from a few years ago compared to the more recent data, the number of instances of assault or coercion kind of were about the same, which is very low, like 1% to 2%. And the thing that I always say to people when I give these presentations is that there were always men included. And so they are uncommon, but when we talk about like M&M or free flat failure or like complication rate, like to me, 1% to 2% is too much still. It should be absolutely zero. So if we were talking about M&M, like somebody experiencing assault or coercion, I think should be zero, like, and then always I tell people to remember that every time I've done these surveys, men have always been some of the people that have reported assault or coercion. So this is not a women problem. This is not like a gender specific problem. It is a everybody, problem that we should all pay attention to regardless of gender.
It is pervasive. There was a study that showed 87% of women have experienced some sort of sexual misconduct. Maybe not directly sexual harassment, but off color jokes, you know. Um, and another corresponding 60 some percent of male residents experience the same. So it's pervasive. And I think it's behavior that has been accepted for way too long, in the operating room, on rounds, et cetera, et cetera. And it does need to stop. And I'd love to spend some time, if we have, talking about how we could correct this kind of behavior. But yes.
Yeah, I
Yeah.
think that's a great place to go to that. What do you think? So when it occurs, obviously there's two different pathways here. The what should we do? And obviously that's going to look different. Lisa, you're in a private practice now, but you've had an academic center, and Wendy, you're in academics now. Those two pathways are different.
Yeah. So just to briefly circle back, just for some numbers, in 2018, in my study, 6.8 respondents of people had reported unwanted touching. So that doesn't qualify as assault, but does qualify as harassment. In 2022, 12.8% of respondents reported unwanted touching. So it's nearly double. And to your point about things needing to stop, Dr. Wu, I think every time I've given this presentation, I've had men, including medical students, residents, or attendings, depending on the setting, come up to me and say, yeah, these things, men have said these things in my presence. And I've thought, why are they saying this? Do they think that I'm okay with this? Do they think that I'm one of them, that this is how I regard other colleagues as well? They like, why are they saying this in front of me? They must think that I'm okay with it. And then number two is, I think part of this conversation has to include our LGBTQ colleagues as well, because that's a totally separate set of data that, can be harassment or workplace bullying or hostile work environment, that sort of thing. And then I'll let Dr. Wu discuss like what she thinks about how people should respond to this.
Yeah, what do you think about that, Lisa? If you're in private practice, if someone, one of your colleagues or person that is in your office came to you and discussed a situation that they made them feel uncomfortable, what's your pathway to address it?
Well, I need to, full disclosure, I have been in quote unquote private practice for about a month now.
Congratulations.
So I can speak a little bit more about my, 16, 17 years in academic practice versus what I can talk about in my own practice of me, myself, and I. But I think that one of the main issues of why sexual harassment, sexual misconduct has been underreported, because there's no question that is underreported, is because a lot of times people think either A, it's no big deal, or B, there will be no repercussions, or C, the repercussions will be against them and not the perpetrator. And I think we need to change that, so that people will be held responsible for their actions, for whatever they say, for the misconduct. And I think that the reporting system has to change. I think that there needs to be a well delineated course of action when something like this happens. And I think that there needs to be a culture change. And a lot of that is also tied to the shift in having a more diverse and equitable leadership.
So I have a number of thoughts about this reporting piece. And I think it's really hard because in our world, it's very rarely anonymous. And so in my research, respondents have reported fear and futility as top reasons for not reporting. Sometimes when people report, they actually get advice to comply with one thing or the other so that they can experience the least amount of blowback. I think that sometimes we have to also separate like what rules apply to residents do not necessarily are the same as applying to attendings. For example, students or trainees actually probably have more protections than attendings. Sometimes if you're a student, then you have a certain protection from the university. But if you're a resident, you're not exactly a student, so you fall under the auspices of the hospital instead. And, is ACGME necessarily totally neutral party? Um, some people think that it may not be because they have a responsibility to the viability of the residency. So you don't want to jeopardize that, you know? Um, and then in other countries, I believe in Australia, and I'm not sure if the UK is involved, their surgical and medical societies do have repercussions where if somebody has been accused of these sort of things, or it's been proven that it's true, that they are barred from their societies. And then, there's a spectrum of what people can do. So, for example, if you're really low on the quote totem pole, maybe you don't feel comfortable reporting to this or that person, or maybe you file a note with HR, but not a formal complaint, because those are different. And there's a whole set of sort of legal, definitions of what has to be like mandatory reporting, let's say. And then maybe what you feel safe doing is documenting to yourself, like writing yourself an email so that it can be like a documentation for later on if you want it. Or just maybe telling one person so that like, you've told someone, and it like that someone can be like a witness. That goes for like your documentation also. Maybe you write down witnesses, or maybe you write down exactly what was said, exactly what was done. Um, you know, uh, if you're in a situation where Title IX applies to you, then, maybe that can be something that can help you. Maybe if there's somebody who has access to like just kind of almost, in our world, we call it curbside, like curbside legal advice, even though sometimes it's not really advised. Like maybe somebody can actually tell you a little bit like of what your options are. And then I think in this world where, our mental health is really important, and sometimes there's, concerns for physician suicide, that's something that we should all look out for each other. In terms of leadership, I think that the Harvard Business Review has noted previously that the more women there are in leadership, the less occurrences there are of this type for both men and women. But if those women are not set up to succeed, then it can worsen the situation. And for people who have been victims of sexual misconduct and harassment, how a leader or how somebody responds to a victim's disclosure can sometimes worsen their experience and make them feel re-victimized, or it can be the difference that makes them, feel better, and even simply just validated, that can make a difference in their healing. So it's definitely a really complicated, very nuanced, difficult situation, depending on what, let's say if you're an intern or junior attending or senior attending, you know.
Wendy, that was great. Great way to break that down. I just have one question about that. Does anybody actually talk to the person that's, I guess, not for lack for a better word, the perpetrator, to say, you've made me feel uncomfortable, or, Lisa, in your case, just curious as to why you asked me to dinner and there's nobody else here. I mean, I wondered, is there a role for just kind of a crucial conversation, a discussion of, this is what I see has happened and this is the way you've made me feel?
I think it's a very difficult conversation to have without somebody, a mediator there, because say if there was sexual harassment or misconduct behavior on the part of somebody, who knows how they would react if you essentially confront them, right? And I think it would be a very difficult thing to do. I mean, in my case, I was a medical student. This was an attending, right? I wanted to go into surgery, and I wasn't even sure if what I was thinking was even part of the equation, right? Like maybe he was just wanted to be a mentor to me, right? Like, so there were a lot of questions there. I don't think I had the I don't think I had the language, the training, or the guts to ask those questions of him at my stage in my career. Now I would have no problem, but certainly not at that time. And I think a lot of people, especially when it comes to power um, inequities, like if somebody was in a position of power over you, to have those types of conversations on your own.
That's an excellent point, right? In that power position role, power play, as the person with the least or lesser amount of power, you don't know what to say, and you don't know how you could potentially even say it or bring yourself with the appropriate words. And you're right. How would that other person respond?
I think that's super key because, especially with some of these serial perpetrators that are very savvy at this, like they could create a situation that has complete deniability. And as Dr. Wu said, like now that this person has behaved this way, you're like, oh, I have no idea who you are. If I reject you, are you just going to be like, okay, cool, move on to the next one? Or are you going to be like, oh, now I'm going to come after you, and like sabotage whatever you have. And like, you have no way to do that. And I sometimes will just counsel people like, do what's safe for you, both one for your physical body, and then two for you to achieve, let's say, graduation or board certification, because like that's the minimum in terms of like, oh, you still have your career, or, you don't jeopardize those things. But, for every person, it's going to be different. In terms of, as Dr. Wu put it, sort of audacity, because I think we should be more audacious. We should be more like, this is wrong. You should not have done this. But in the end, like we also all have worked so hard, so many years, sometimes with a lot of financial debt, that it's hard to, put that at jeopardy when you're in this type of situation. And I think that the concept of serial perpetrator is very valid, because sometimes people have been doing this for so long. They like, if you're experiencing it, I think it's important for some people to understand that you're most likely not the first and not the last. So you may think, oh my gosh, like, this is happening to me. It's not something that happens every day, but maybe this person's like been doing this for decades, to nurses, to trainees, to junior attendings that have never, reported them or had any accountability. And, but I think a lot of times these people are serial perpetrators. And just, there's been some literature that, especially in an academic environment, or sometimes even not, we've all heard the Dr. Death podcast, or the series, watch the series. But like a lot of times physicians are permitted to just, leave without, quote, officially being, quote, fired, leave without official repercussions on documentation, and they just go somewhere else. And I think something like half of people just go somewhere else, or if they're kind of a certain age, they're allowed to gracefully retire. But these people these cans just get kicked down the road because a lot of leaders, they just don't want to deal with it. A lot of people, they can keep their medical license, they can keep their like professorship or whatever it is. And it is a very hard disease on our community to eradicate. And I think that's why, when people talk about the environment, we don't need everybody doing it perfectly. We need everybody doing it to some degree on the spectrum.
Right. That's a great point. We don't have all the answers. We don't have the exact pathway of how, when this occurs, what exactly to do. Because you're right, it's very different in each situation, and a large part of this is personal safety, making sure that you stay safe physically as well as mentally through the process. So historically, many people have stayed silent in this environment. It sounds like if that happens, we haven't really helped future generations. If there was a pathway that could be created, or a protocol, Wendy, what do you think that might look like?
I think kind of in the vein of what we've been talking about, it's kind of like activating allies. So the United Nations Women has a study or document or like a book about promoting culture change to end sexual harassment. And when we talk about sort of activating bystanders, even a little bit or a lot, like if somebody's already aware of the situation, to motivate them to be more active. If somebody's already active, motivating them to be like more, like when we talk about sponsorship instead of mentorship, just making everybody more active and bringing it more into the conversation, and getting leaders to be more active and interactive in terms of facing this. So, like in residency, my program director said, "Run towards fire." Like in M&M, there's a lot of uncomfortable situations that we talk about, and I think this is also one of those. We just gotta get comfortable with discomfort so that we can grow and progress.
That's a really great point. Lisa, if you had to talk to the medical student within you now, and someone came to you with a similar story, what would you tell them now?
First, to validate what they're feeling, right? Again, I think for me, it was kind of like, is this okay? Is this not okay? Was this weird? I'm not quite sure. And I think if somebody came to me with the same story, I would be like, what you're feeling is valid. And if you were uncomfortable with the situation, then there is something there that's going on that was not correct, right? So again, to number one, validate that what they're feeling is correct. Number two, to make sure that they are supported, right? Like they need to know that it is not okay. It is not okay to be in a position in which you're uncomfortable because somebody is acting, saying things, doing something of the nature, sexual nature, that makes you uncomfortable and it's unwelcome. Absolutely. Make them understand that there are ways for them to report it. If that they're safe, if there's a safe place, and that they can tell people, they can report it, and it will be listened to and acted upon appropriately. And again, I think that it's very important that there are institutional guidelines and a policy in place that is followed, and that again, when I was trained, it was pervasive. It was okay, and that can't happen anymore. It just can't, and it's a culture change, and it has to be a culture change that starts from the top and goes all the way down to the bottom, including, as Wendy had mentioned, relationship between patients and doctors, relationships between nurses and doctors, relationships between colleagues, all at every level. Yeah. So
Yeah, I mean, it just makes your toes curl like, OMG.
yes.
It's terrible. But you're right. I mean, in the larger institutions, there's HR. Well, first your program director if you're in training, and then as a employee, HR is always available as an option. And then if you were speaking to different listeners to this, if you're in private practice, you're right, talking to colleagues or other people within the practice in order to build almost an alliance, validate the feelings, and determine if how pervasive is it happening to everyone. And then it becomes a matter of, do you escalate it from there, or there's a component of, do I leave for my own personal safety and mental fortitude? Wendy, what would you say to that person?
Yeah, I would say that based on our research, physicians are not always the most common target. It's often subordinates, which makes sense from the power differential we were talking about. So patients, PAs, nurses, right? Like if you're getting it as the physician, I would be willing to bet that there's other people. And so I think in a lot of these situations, the concept of you are not alone, you are not alone, you are not alone, and also the whole gaslighting bit, like you're not crazy, you know? And then sometimes when I've given these talks, there have been people who are like, oh my God, what? These are stories that I've never heard before. And I was like, oh, well, maybe there should be more discussion then, because there's a certain demographic of people for whom stories like this are like, oh yeah, commonplace. Like, no matter how crazy the story gets, people are just like, oh yeah, and there's a certain demographic for which these stories have never been unearthed and brought into the light. And so again, I think the talking about it part, because these are facts, right? These are never events that are happening. Fact. Okay. So they exist. Okay. So then there's only two options. You make progress or you make excuses. It's like in residency, we say, come with solutions, not problems, And so there's no excuse. Oftentimes in some other fields, there's some fields that are also quite bad, right? Let's say, for example, maybe Silicon Valley or business or whatever, right? But like for some other professions, there are people who hear our stories and they're like, what? This is so antiquated, or shouldn't physicians be held to a higher standard? And they're shocked at some of the behavior and the words that are permitted in our culture. And so, that's the gap that we have to close.
Do you think that there's a difference between location? Lisa now is in Florida, you're in Texas. Do you think it's different in larger cities versus smaller, more regional areas?
I really think that it's sort of even more microcosm than that, because my boss is like nearly 7 foot tall and gay. So our department has I think we're 8 or 9 people, 2 gay surgeons, 3 females, and so yeah. And I'm in Texas, true. I'm in Houston. It's a very big city. It's the most diverse city in the United States. But I think, my boss built this division with this demographic in mind, And so I think to Dr. Wu's point, it kind of comes down again to, and when you had the Louisiana Purchase, it comes down again to leadership. I think that yes, leaders are important, but also when you talk about individual leadership versus divisional or institutional leadership, I think it's all levels need to be targeted. So grassroots from the individual level, just me within myself and my individual integrity and standards and principles, what I believe, as well as what your institution has put out there, So when I was a fellow at UCLA, they had a journal club that was made up of everybody, at the hospital who wanted to participate, and it was specifically for diversity. And one of the first ones that I participated in, they gave out free, quote, movie tickets. It was the pandemic, so you just got free access to like a documentary about how few Black male physicians there are in the United States. And then like people got together and talked about it. So that's like one thing, and now in the sort of not quite post-pandemic, but the pandemic spawned a lot of sort of digital opportunities and networking opportunities and resources and podcasts and webinars, all these things. I think there's more opportunity than ever. For example, this, right? The ASPS University, more than ever, there's opportunity to expand your own mind and practices with regards to these things.
Very well said. I mean, I think you're right. There's no distinct one method to do this, but it sounds like there's power in numbers to speak out to anyone and everyone that will hear you is the first part of stopping the silence and acknowledging that it occurs. And then, one other idea here, one other situation that we haven't really said very much is, what happens when it comes down to um, where it's an individual or an enclosed environment. So not in the operating room where you can corroborate stories, but a one-on-one situation. I mean, do you feel like if Lisa, do you feel like if a division head had someone come to them and said, so and so said this to me, it made me feel uncomfortable. It seems like it's not necessarily that you have to have other people in the room to believe that person. What do you think?
So no, I think a lot of times things happen when there isn't other people to collaborate the truth or a story or a statement or an action. And I think people who are perpetrators probably know that and seek out situations in which there is nobody to collaborate or corroborate, excuses or what actually happened. So we need to get away from saying, well, do you have proof? They don't need proof, right? They need to be believed to an extent, and it needs to be taken seriously, and it needs to be investigated. I think that answered your question, right?
Absolutely. Yeah, absolutely. I mean, that's a big part of this. If someone out there is listening to this and feeling like, well, I wasn't in an open situation. I wasn't where someone else could see us and back up my story about what I heard. But I do know I felt uncomfortable and I didn't feel right. And I think absolutely what you've said is that if you can listen to your intuition, if it doesn't feel right, it isn't right. And that could be the call to say, I need to talk about this and acknowledge that it really happened, just like you had said earlier, validate it, and then discuss next steps, whether that's to go to HR if that's a possibility, to speak out to others, to create an allegiance of people that you can communicate with. And then obviously, Wendy, you've talked about, people leave their work environment, for safety if needed.
I mean, I think it's also important for people to know that there's more than the one option of formal complaint. You know what I mean? So like there's a spectrum of ways that you can make things known and a spectrum of people along the hierarchy that can be the person you make it known to. And even let's say it doesn't become a formal report or investigation, there could be one person that could be like, oh, this is the fifth complaint, like fifth story or incidents or 10th, and that could be something that's being collected. Number two, for people who think, well, why does there not need to be evidence? You can make anything up. I mean, I think there are 0% of female surgeons, or not just female surgeons, anybody in this world or in the surgical community that wants to be like, hi, like I was the victim of X. Nobody wants to, one, to make that known to somebody is really kind of, it shouldn't be embarrassing, but your immediate emotional response to having experienced something like this or telling somebody is not positive. You don't want to be labeled that. And so, and then what gain, and there's a lot of emotional burden and all these other consequences to having this situation attached to you. And so for anybody who thinks like, oh, well, then people can just like go all around and say this and that about anybody, like that is, in the layperson reporting, that is so vastly the minority of cases, these false accusations, that it's just not, that's not, the most likely scenario by any stretch of the imagination.
Right. It wouldn't be the standard because there's so much to be lost.
There's so much to be lost. There's
Right.
pretty much nothing to be gained. So much to be lost. Yeah.
Right. Your reputation, your status. And so it takes so much to move forward with it. So as we, kind of, wrap this up a little bit, any last ideas that, when we look at this, that we should say, that we could tell people who are listening to this of what to do and where to go? Wendy, you want to start?
Sure. I think the number one thing is that no matter who you are listening to this, like if you're a surgeon or not, if you're a student training, or if you're, plastic surgery or not, whoever you are, there's things that you can start doing today, right? To advance like your perception of this topic, or do something, say something, there's something that can be done to improve the situation already today. And so no matter how small, there's something that you can do. I always use this MLK Jr. quote, like, if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But by all means, keep moving forward. To be an ally is a verb, it's an action, it's a verb. And let me think about, there was one other thing I wanted to say, but I think that's it, that we need to keep chipping away to make it better, because I think we all come into this profession to be helpers, and we need to change our culture.
Yeah, well said. Lisa, what do you think?
I think one of the biggest things that I wish that I did and do is, if you see something, you need to say something. Even if it isn't you being the one who's harassed, or it's directed to you, etc. If it's to somebody else in the room, or that you know about, you need to say something, because the more we ignore it, the more it's going to just go on unreported, and it's basically, well, it's basically giving the okay that behavior can continue, and it can't. And I've been in plenty of situations, I can name them over and over and over in my training, in which things, inappropriate things were said, or I saw inappropriate things, and I never said anything, right? Because nobody said anything, and we all laughed, and it was funny, and it was accepted. And but looking back, it's not okay. And I think excusing that behavior by not saying anything is just as bad as, maybe not as bad as being the perpetrator, but it's bad. And if there's any advice that I could give, or anything that I could do differently, is to say something if I saw something happen.
Yeah, I know I'm butchering the quote, but I think it's omission is permission, or commission, or something like that. But basically, what you permit, you're promoting. What you're allowing, you're encouraging. If you're the senior attending in a room and something happens, you don't say anything, everybody in that room is like, oh, this is okay. This is the standard, and this is okay. And I think, we are talking about it as plastic surgeons here, but at PRC in Toronto, I said something like, it's very rare that there's a specialty like ours that touches everything. Rheumatology, internal medicine, infectious disease, pediatrics, like we interact with everybody. And, there are other specialties that I'm sure like interact with a lot of other specialties. So see something, say something is for everybody, because it's not just our specialty. It's everybody, right? Everybody in the hospital, everybody that it touches, that it's the culture of everything, not just our specialty.
And I also want to say for, for those that are listening, if you're a medical student, I'm not saying that you have to call out the attending in the room if that's the person that's acting poorly. You can literally step aside, put your hand on the nurse's shoulder or the resident's elbow and say, don't touch them anywhere else, but and say, hey, are you okay? I heard that and it wasn't cool. That sometimes is enough to make sure that that person knows that they're not alone and that what occurred was not okay and that how they're feeling is validated.
Oh yeah, you can just say something like, "Oh, what did you mean by that?" Or you can like drop something, right? Like you can just interrupt the behavior in some way. Yeah.
Right. It's a non-violent, but a way to stop the moment and acknowledge that something has happened. And 100%, it doesn't have to be the attending. It could be your chief resident, your fellow resident, the person standing next to you, an acknowledgement of what has happened, and I'm not feeling comfortable about it. And you're 100% right. Unless we start now, silence doesn't help any of us, and doesn't advance us or this situation. One last thing with this too that I think is important to mention, that it happens, and everybody's a part of this. It's men, it's women, it's all of us, that we need to protect each other, that they're all united in this, and we depend on each other for safety. So while we don't have all the answers, I appreciate you both, Dr. Wendy Chen and Dr. Liza Wu, for sharing your story, your research, your perspectives on sexual harassment and misconduct in today's Limitless Leaders podcast with our listeners. You've both been excellent guests, and I'm grateful for this time.
Yes, thank you very much for an incredibly enlightening hour of conversation that has made me think deeper about my actions and how I will go about dealing with these sorts of situations now that my situation has changed. So I really appreciate it, and thank you for all the facts and the suggestions and the tools that we can arm ourselves with moving forward.
Yeah, thank you so much to ASPS University for making this a topic of discussion. I really hope that it becomes a nidus or a seed for further discussion for different communities and divisions and departments moving forward at Grand Rounds or at journal clubs, just to keep the conversation going. Thank you so much.
Thank you for tuning in to another episode of the Limitless Leaders podcast series, brought to you by ASPS, the Aesthetic Society, and the American Hernia Society, with the generous support of Allergan Aesthetics. We hope you enjoyed our conversation today and gained valuable insights and inspiration from our guests. Please check out other episodes of your favorite podcast platform. You can download them directly from ASPS EdNet. Stay tuned for new seasons, exciting new episodes where we will continue to celebrate and empower women leaders in plastic surgery and in general surgery. Thank you.